All right. Okay, Dr. Geoffrey, you have the floor.
Okay, thank you. Thank you, our facilitators, our teachers and colleagues. My name is Dr. Geoffrey Okatubo, and I'm taking practice question 5. So the question is, number 1, define team in your own words. List 5 qualities of a good team leader. You are the head of a team in the hospital that consists of both clinical and non-clinical staff. These 5 qualities that you will display to make your team an effective one. Mention 4 benefits of teamwork to the patients and 4 benefits of teamwork to the facility. So the answers, the first one, define team in your own words. A team is a group of individuals with different skills, knowledge and abilities who work together to achieve common goals or objectives. 2, list 5 qualities of a good team leader. These are respect, integrity, collaboration, gratitude, and vision. Then 3, you are the head of a team in the hospital that consists of both clinical and non-clinical staff. List 5 qualities that you will display to make your team an effective one. First one is effective communication. 2, commitment. 3, empathy, motivation, and capacity building. Number 4, benefits of teamwork to the patients. 1, they have enhanced satisfaction with care. They improve health outcomes, reduce medical errors, and quicker recovery for the patients. And 5 benefits of teamwork to the facility. The first one is comprehensive health care. Of course, collaborating with colleagues ensures that patients receiving holistic care. Then reduction of error. Multiple eyes on a case help detect mistakes and prevent errors. Efficient workflow. When everyone works together, tasks are completed more efficiently, leading to quicker patient recovery. And services are also better accessible to patients. So I'll now go through teamwork as a topic. There are different definitions of teamwork, and I have a few here. So a team is a group of individuals with different skills, knowledge, and abilities who work together to achieve common goals or objectives. Another definition is a team is a cohesive coalition of people working together to achieve mutual goals. Another one, again, is a team is a small number of people with complementary skills who are committed to a common purpose, performance goals, and approach for which they are mutually accountable. Okay, then WHO also defines a team as a group of 2 or more individuals who interact dynamically, have a common goal or mission, have been assigned specific tasks, and possess specialized and complementary skills. So how do teams form? There are 4 known stages of team formation and development. The first one is forming, where team members come together for the first time to introduce themselves and know themselves as a team. 2, storming, when they start discussing about the general goals and objectives of team and of the team and sharing various responsibilities. At the stage of norming, they have come to agree on who carries out specific responsibilities, roles and responsibilities, and generally the team's goals and objectives. And the 4th one is performing, when they start carrying out their various functions. So the types of teams found in healthcare include the core teams. The core teams usually are populated by those who are leaders of the team and those who are directly involved in the management of patients, like the doctors, nurses, pharmacists, and the patients themselves, and of course, cleaners and other staff. Then the coordinating teams will generally carry out the day-to-day activities of the team, coordinates the day-to-day activities of the team. The contingency teams are usually set up for emergency purposes, for instance, rapid response team, cardiorespiratory teams, and all that. Ancillary teams generally assist in the carrying out of, assist the main team in carrying out their functions, while administration may even include the leadership of the health facility. Examples of teams in healthcare include infection control team, medical emergency response team, disaster team, transplant team, diabetes mellitus teams. Then there are some barriers to teamwork, and the first one is unclear definition of roles. If roles are not clearly defined, so of course there'll be clashes, and there'll be times when people will not carry out their expected functions. Then lack of explicit coordination, particularly when the leader of the team is not really effective. Miscommunication, when there are no clear lines of communication between the team members. And instability of teams due to transitory nature of teammates, particularly when teammates are transferred from one unit to the other. Then I want to also talk again about the qualities of a good team leader. Respect, where the leader of the team values the perspectives of others, whether or not they are junior members of the team. Integrity, doing what is right always. And compassion, you act on what you learn, speak up boldly. Collaboration, that's working across borders, showing appreciation regularly. And the vision, the leader of the team should have a clear vision of the team's goals and objectives, and also be able to influence others to act towards carrying out the functions of the team. Communication, the team leader should be able to communicate clearly, to have good communication skills, both in writing and orally. You should also be able to learn to adapt to new situations, develop the capacity of others, particularly team members they know are not very functional in their various teams, or because they don't have the necessary skills, and delegation of responsibilities. Features of a successful team: team members should be able to speak freely within the team and support each other, effectively solve problems collaboratively, and have a clear sense of direction. There should also be adequate resources for the team to use, and they should also be able to trust each other. What makes a successful team? Effective teams possess the following features. One, they should have a common purpose, measurable goals, which they should be able to carry out self-check within the team to see whether or not they are able to meet their specific goals. Effective leadership and conflict resolution, good communication. They should all work as a team always and have mutual respect for each other, carry out situation analysis at intervals, be able to monitor themselves, and of course, teams should also be able to have flexibility. So in conclusion, team means together, everyone achieves more. Thank you. These are my references.
Wow, thank you so much, Dr. Geoffrey, for that lucid and concise presentation. You really kept the time. Okay, so at this point, we'll take comments and questions from the participants first. And then let's keep the things coming on the chat. So on the chat, Dr. Florence is saying, great job. Please, Dr. Geoffrey, please, I didn't really get the benefits to the patient. I don't know, can you just take that and click that again?
Okay. Okay, benefits to the patient. Okay, sorry, it looks like I skipped it. Enhanced satisfaction with care. Second one is improved health outcomes, reduce medical errors. Of course, when several eyes are on a case, mistakes are easily detected and errors prevented, and quicker recovery for patients. When the team works together, they tend to be more efficient and leads to a quicker recovery for the patients.
Okay, wow, thank you so much. Okay, some comments on the chat. Dr. Justice is saying, thank you so much. Awesome presentation. Dr. Jamila says, thank you. Dr. Adimbola, Dr. Jafaru. Chief Okop is also saying, thank you for your concise presentation. Dr. Irabatom says, please, which set of people make up the coordinating team?
The coordinating team are responsible for the day-to-day management, the operational management of the team. And they carry out the coordinating functions of the team. So the leadership of the team should be part of the coordinating teams. Hello?
Dr. Tom, are you okay with that response?
I just thought there were some other people apart from the doctors, since he mentioned the people in the core team, the set of people in the core team. I thought there were some other people in those team. All right, thank you.
Okay. So any more comments or contributions? I can't see any hand on the chat room. Okay. Okay, so if there are no more comments from the participants, I'll go over to our teachers. Dr. Chris Weber.
Okay, thank you so much. The presenter did a good job, did a wonderful job. So I want to hear from Dr. Dahatu. The exam experience will come in after we're done with the...
So in your own terms, sir, can you tell us what you think a team is?
Okay. To be candid, I actually did not read up this particular definition I gave, but I think a team is a group of individuals who come together to carry out specific functions. They may be from diverse backgrounds with different capabilities and skill sets.
Yes, and of course, they are all aiming to achieve the same goal, which is the most important part of that definition. Okay, so even though they are different, they are all coming together to achieve one goal. I think we have to be sure that whenever you ask the question, please always try and answer it the way they said you should answer it. So in other words, they don't want you to sound like a textbook. So they want you to sound like you're having a discussion. You know, you could start by saying something like, you know, there's a popular saying that says there is no I in team. So a team is a group of people. You understand? So they know that it's not a textbook you're reciting. It's coming from your head.
Okay, thank you.
All right. Thank you. You're welcome. Yes. Well done.
Hello?
Hello,
everyone.
Can go ahead.
Yeah, good morning. And thank you to the presenter. He did a beautiful job. Me, I always like to bring another twist to everything, so don't mind me. But I'm wondering, this your team, everything just seems rosy, beautiful. Are there no checks and balances? Are there no, like in this our team now, for example, this our part 2 team, I'm the chairman of the disciplinary committee. So it's an important part of the team. I've not seen anything disciplinary in this your beautiful team structure. So is there a rule for that? Thank you.
Yeah, I think there should be a role for a disciplinary, somebody to be in charge of discipline, because like you said, there are sometimes some members of a team may want to loaf around, and there should be somebody to carry out checks and balances to make sure people don't do what they are not supposed to do in the team. I agree with you, but I didn't think of it actually. Thank you.
Okay,
Okay.
It's okay. I think we can go on.
Okay, there's
Yeah.
a question on the chat. I don't know if you can take it.
Go ahead, please.
Is auxiliary team and support team the same? And then let me just add mine, just like Chief Erigo said. I don't know sometimes that the team could actually go wrong, and then instead of us looking at the benefits to the patient, now the kind of fall drawbacks to the patient. Okay. Chief Jeffrey, please go ahead.
Okay, so ancillary teams and support teams look a bit similar, but the ancillary teams are, you talk about people like the cleaners and domestic staff, while support are mainly those who assist in the administrative running of the team and carry out specific tasks within the administration of the team. So they look similar, but are really different. Ancillary domestic staff, the cleaners and all that, while the support staff are those who support in the running in the administration of the team. Sorry, then the last question, I didn't get you, please.
Okay, I was asking if there are times the team could go wrong.
Within a team. Well,
Yes.
that is why they have to be carrying out a situational analysis at intervals to know if they're actually achieving their purposes. And of course, when they carry out such analysis and find out they're not meeting up to their standards, then they will sit down again. The team sits down again and plans to fill those gaps they have identified. And that actually running such an activity is supposed to be the work of the team leader, who is expected to have a clear vision of the team and make sure the team carries out and work towards carrying out that vision. I don't know if you have any other thing you want to add to that, please.
No, thank you so much. Okay, ma. I don't know if you can. Okay, there's this. Thank you for the wonderful presentation. Is there a possibility of having a sub team within a team?
Yes.
From Dr. Ade.
Yes, there's a possibility of having a sub team within a team, because, for instance, if you have a large team like a disaster management team, there should be various sub teams within that team to carry out specific functions, which may not necessarily have to be carried out by the entire team.
Okay, thank you so much. Okay. I don't know if we can.
We can move to the next question, please.
Okay, thank you, ma'am. Okay,
Thank
please,
you so
O'Shea.
much. Thank you.
Thank you.
Okay, Dr. Florence, please share. Hello, Dr. Florence.
Sorry, please, Dr. Kele. Somebody was supposed to talk to us about the expectations from the examiners. We've not heard that.
Okay, please, at the end of the class.
Okay.
Hello, Florence, are you there? Hello. Hello, Florence. She can't hear me. Okay.
Chief Ikele, you want us to share a presentation?
Yes. Okay, let me send it to you, please. Dr. Mahmoud, help me share. I had already sent it to Florence.
Okay.
No, she's not. Okay, please share.
Can I go ahead? Good morning, teachers and senior colleagues. Thank you, Dr. Mamodu, for helping me to share my slides. So my name is Dr. Temitope Fakonda, and I will be answering the... Hello?
I'm so sorry. I'm so sorry about that. I think I was logged out.
All right, it's okay. It's okay.
Sorry.
Thank you. Okay, Dr. Temi, please go ahead.
Okay, thank you. Okay, so the question states that a 45-year-old man with hypertension was on hydrochlorothiazide 25 milligrams daily, but the control was poor. So captopril 25 milligrams BD was added to the medication. There was a history that the patient collapsed after taking the drug. So, and then these are the questions. So what is the possible cause of the collapse? What is the underlying mechanism of the above? Which people are at risk of the condition above? Who should take responsibility for the fall? Will you stop the medication? What will be your line of action? All right, so for the first question, what is the possible cause of the collapse? So I think the patient had syncope due to postural hypotension. Then the second question asked for the underlying mechanism of the above. So I think it's as a result of ACE inhibitor-induced first dose hypotension, secondary to the captopril that was added to the medications. Most likely the patient collapsed after taking the first dose of the drug. So which people are at risk of the condition above? So patients who are volume depleted or dehydrated, which is a possibility in this patient, he was on hydrochlorothiazide, patients on diuretic therapy, like this index patient, patients who are hyponatremic, patients on diuretics as well, or on a low salt diet, and then patients on antihypertensive polypharmacy. So patients are already on 2 or more antihypertensive drugs, and then adding the ACE inhibitor could potentiate this effect. Then patients in heart failure, elderly patients as well. So those are the categories. So who should take responsibility for the fall? So it should be the medical team, the team, which includes the prescribing physician. So that I will admit to the patient that the captopril was the likely cause of the syncopal attack, even though the drug is indicated for the patient to optimize the blood pressure control in addition to the other potential benefits of the heart and kidneys. But necessary precautions were not instituted when the medication was added. So I will apologize to the patient on behalf of the medical team. So the next question asks if I will stop the medication, and my answer is no. I will not stop the medication. So my line of action will be that I will reduce the captopril dose to 12.5 milligrams twice daily, and then I'll ask the patient to use the first dose at bedtime, as this will help to reduce the risk of the patient having a fall, as the effect would have worn off by morning when the patient is awake. Then I will also ask the patient to temporarily stop the hydrochlorothiazide for the first 48 hours of starting the captopril, and then to continue using it Then at this visit, I would like to assess patient baseline serum electrolyte urea creatinine, and plan to review this at a follow-up visit with the patient. Then as well, part of the instructions I'll give to the patients will be to perform home blood pressure checks and record the readings and bring them along for review at the next clinic. And then so I will let the patient know that depending on the blood pressure control, the captopril will be gradually titrated upwards at subsequent follow-up visits. Thank you.
Thanks so much for the beautiful presentation. So now we'll take comments, questions from the participants first.
Okay, good morning, everyone. Good morning, facilitators, senior colleagues and colleagues. Thank you so much for that beautiful presentation. Just an add-on. Okay, so as regards question number, who will be at fault? So I was thinking not just the doctor alone, the pharmacist should also be part of persons who should be at fault. Why? Because when drugs are supposed to be given, the pharmacist is supposed to tell the patient what and what to do. Like, for example, medications that you need to eat before you take the drugs, the pharmacist should give the instruction. Like a drug like the ACI, that's the captopril we just talked about. Such medications, instructions like you should be lying down when you take the medication should be told to the patient, because once the patient takes that drug and then sits up in the first 4 hours of taking that medication, what happens is that the patient is at risk of orthostatic hypotension. So it's advisable that that patient should get that drug at night. And then also it's advisable to tell the patient to be well hydrated before taking the medication. Then also from the aspect of the doctor is supposed to start at a low dose. Such medications are supposed to be given at a low dose. Then gradually it will be increased upwards. So in blaming the team, I think the pharmacist has a role also to play by educating the patient and also advising the patient that this is an expected side effect you're supposed to see in this patient. Then in addition, people who are at risk of such condition, the elderly, teenagers with growth faults, and also people with comorbidities like diabetes, hypertension, and then also kidney and cardiac diseases are patients who also at risk of such conditions. Then also, yes, as you said, I don't know whether, looking at from our guidelines in hypertension, I was thinking maybe the patient would be on an ACI and then you remove the HCT and then put maybe a CCB. My own thinking, like you give a calcium channel blocker to replace the hydrochlorothiazide, because hydrochlorothiazide has been said to cause orthostatic hypertension. So I think it will worsen the effect of the captopril given to this patient. Maybe we can replace the calcium channel blocker, which, looking at our guidelines for taking care of a patient with hypertension, a CCB as well with an ACI or an ARB. So that's my own thought. Thank you so much.
Thank you very much, Chief. Okay, so I know that our chiefs from the exams will give us some insights, but I tried to also reach out to one of the people that was in the exam, and they mentioned that the patient was on actually some other medications, not only hydrochlorothiazide.
Okay, thank you so much. Okay, so some chats on the chat box. Okay, so good, Dr. Ojimi is saying good morning. Thanks for the presentation. When does patient receive morning dose of captopril? And then Dr. Adesokan, checking the blood pressure of the patient both in supine and sitting and standing will also be beneficial. Thank you. Okay, so when does patient receive the morning dose? Hello, Chief Temi.
Okay. Okay, so yeah, for the ACE inhibitors, actually, it's this captopril that is short acting that requires it to be given twice daily. So what's just the morning dose will still be taken in the morning, probably around when the patient is having breakfast. It's because the captopril is actually short acting. So it's twice daily. So it's just advised that the first dose should be taken at night to because the postural hypotension is it's a first dose effect. So it's not something that we expect that will keep occurring in the patient. So it's just that the first time the patient is using the first dose, it is best used at night to mitigate that and prevent the patient from falling. But subsequently, there'll be a morning dose and an evening dose, preferably at the same time, so the patient is consistent.
Thank you so much. I saw Dr. Linda's hands up. Dr. Linda.
Okay, thank you very much. Good morning, our teachers. Good morning, participants. Thank you for your presentation. Please, I just want to also add a little and ask a few questions. So I know that HCT with captopril, there's a synergistic effect, and then when you're giving it together, I think it's a daily dose because of that synergy. So captopril BD, I think in the first instance is wrong. Maybe the cardiologist will correct me, but BD already is wrong. Then I also agree with the person that said you should have checked the blood pressure. And I feel you should have also answered the question based on the blood pressure of the patient, whether you'd, withdraw the medication or continue because of the synergy. And so it's likely, because of the synergistic action, we'll likely not have only the first dose hypotension. We might have subsequent hypotensive episodes. So thank you.
Thank you very much for the contribution. Well, captopril is BD. It's not all the ACE inhibitors. Most of them are actually daily, but captopril in particular is short acting.
Yes, but when it is given with HCT, it is a daily drug. Please check it.
All right, I'll check it. Thank you.
Okay, well, thank you so much. I don't know if any cardiologist wants to react before we go to our teachers. Okay, I can't see any hands up. And no other chats in the chat box. Okay, so please, we'll go over to our teachers now. Mark Christabel.
Oh, Dr. Eke, thank you so much. I appreciate all the speakers, the questions, the comments. Dr. Tomomodo, thank you for sharing. I think the presenter did well. I don't know, this set of presenters, they keep to time really. It was quite eloquent. I really don't have any addition. I think for that question, Dr. Kopi, any comment? This is your area. Dr. Kopi, Dr. Fatima. You guys are in-house cardiologists. Any comment, please?
Yeah, well done, Dr. Sorry, is it? Sorry, Temitope for the presentation. Yeah, captopril can actually be given up to 3 times daily, depending on the blood pressure of the patient. So looking at this scenario, I don't think the captopril should be continued because a patient that collapsed because of postural hypotension should be monitored for at least 24 hours with close BP monitoring rather than just reducing the drug down to 12.5 milligram BD. It's better you suspend the drug, you monitor the blood pressure, because from the question, I didn't see anywhere where blood pressure is given. So even if it's not given, you consider adding a second drug depending on the patient's blood pressure. It's not a hard and fast so that you must give 2 drugs to a patient. No, it depends on what your target is. But captopril can be given up to 3 times depending on the blood pressure of the patient. I think this is my comment. And mind you, whenever you are answering a question, always look at the heading. Because if you are not talking in line with the heading of that question, you may not get the desired mark. So always have that in mind. You need to look at the heading of that station so that you answer the question in line with the heading. So it's more of communication rather than management question. You need to communicate very well with the patient as well as the patient relatives. Thank you.
Thank you, Chief.
Thank you, Dr.
Hello?
Thank you, Dr. Fatima.
Hello, good morning. Sorry, I couldn't put away my hand. I'm driving. Sorry, this is Dr. Shitu. Good morning, Dr. Christabel. I think Dr. Florence, and well done, Dr. Fatima. You think you shared some of my thoughts on this particular question. First things first, why is everybody calling the cardiologists? Cardiologists don't manage hypertension. It's the nephrologists that do that. Happy Dr. Remigos. Am I wrong?
Chief Shitu, you are bringing
I'm not,
controversy.
no, I'm not bringing controversy. I'm not, because there's a specialty under nephrology that is just for hypertension. Yeah. So
Yes,
I don't think there's a
you
specialty
are
under
correct.
cardiology that is for hypertension. So please, if you have a problem with hypertension, see a nephrologist. Okay? That's just banter. All right. So, but for this particular patient, yes, I understand. They may not have given us the full information, but perhaps there is more to this patient than meets the eye. But whenever you're faced with a drug side effect, you many a times want to look at what are the factors from the patient, and then factors from the medications the patient is taking, and factors on the disease entity that the patient is taking the drug for. So that's the easiest way to look at it. So any drug that you're given, it may not be as simple as this one, but it may be a lot tougher. But once you can look at it from the point of view of the patient, the other drugs, and the condition itself, then you can figure it out. Then yes, I want to lend my ear to the speaker that mentioned captopril being given with HCT and given once a day. Yes, sometimes people do that, but ideally the captopril should be given at least twice in a day, because it has a half-life of about 6 to 8 hours. Thus, it's better to give it more than once a day if you want to see the full effect of the drug. Okay, so yes, you can actually do that to it. Give it daily, but that would depend on what you're trying to achieve for the patient, and of course the patient's blood pressure control. Then also I want to agree with Dr. Fatima that yes, the patient should be stopped on all antihypertensives for at least 24 hours, and then you reintroduce the antihypertensives one after the other and make sure the patient is fine, because both the HCT and the captopril could have caused the the orthostatic hypotension and all of that. So it's important that you stop everything and then we introduce them one after the other. Those are just my submission. But well done to the presenter.
Yes. Thank you, sir. So just to add that even when you, thank you, Dr. Fatima, Dr. Florence, when you're reintroducing the drug, you either start one after the other or start at half the dose and then monitor before you commence the full strength with the dose of the drugs. Thank you.
Yeah. Chief Amigo, sir, Dr. Kopi, Chief Chitu, thank you so much, sir. Thank you. Chief Amigo, sir, you have the floor.
Hello, can you hear me?
We can hear you now,
Hello?
sir.
Oh, sorry, a call came in. I just want to quickly ask that that mechanism of the hypotension, is it enough to just say acei-induced first dose hypertension? Or do they really want you to talk about the mechanisms, maybe all those other bradykinin?
Hello, sir, we lost you.
Hello?
The network is unstable, sir. We didn't hear you.
Yeah, I'm trying to get through to me, but I'm talking about the mechanism. Is it just enough to say the way she said it, or is it important to talk about the actual mechanisms, like the bradykinins and then the vasodilatory effects and all those things? Is it important to talk about those ones? I think that's just my question. Thank you.
Hello, ma.
Yeah, I think just to, sorry, we don't waste the time. Yes, it's important to talk about those other mechanisms, particularly if we're talking about the first dose effect. Okay, and of course, we know that many of these other pathways are also responsible for many of the side effects that we see with ACE inhibitors as well. So it's important to mention all of those factors. Then, so I forgot to mention when the earlier speaker mentioned the pharmacist also being involved. Well, I wouldn't want to put the blame in front of the pharmacist because the pharmacist is not the head of the medical team. Okay, it's just a member. So it still falls, the buck still falls on the head of the person in charge of that clinic. Even if it was not the person that prescribed it, whoever is the head of that clinic is the one that is going to take the wahala from this particular patient. Okay, so the person has to basically take it because ideally, whenever you give a patient a new drug, you should also tell the patient about the possible side effects. It's like blaming the pharmacist for somebody going to hypoglycemia after taking insulin. You won't blame the pharmacist because the pharmacist doesn't know the patient as well as you do. So it's still, the buck still falls on the doctor's desk. Yes. Thank you.
Okay. Thank you, sir. I appreciate your comment. Thank you so much. Thank you so much, sir. Doctor, I think we're done with this particular question. Dr. Kele, is the third speaker ready? Let's see if we can quickly take that.
Yes, ma'am. Oh, Dr. Fabemi. Dr. Fabemi. He's on the chat.
Hello, Maya, I'm ready.
Okay, please go ahead.
I'm sorry, I'm unable to share the slide.
Okay, let me achieve.
Okay, let him send it to me or to
No
the
problem.
platform.
He puts it in the platform. Okay.
Hello, Florence, are you there? Okay, I think that's someone who can share.
Okay. All right, Mama, just share. I think I'm going to the wrong way. Okay, just share, Mama. Thank you.
Good morning, sirs, our teachers and colleagues. I will be talking about answering the question 6, the question on acute medicine. The questions are: a 25-year-old female known to have sickle cell anemia presented with a 2-day history of worsening chest pain and presented with no fever. Mention 3 differentials. What other issue you take from this patient? What is the likely diagnosis? What other crisis can this patient have? How will you do a chest examination of this patient? What investigation will you carry out? How will you treat this patient? And 4 other indications for use of hydroxyurea aside from acute chest syndrome. So this patient, biodata background, young lady with chest pain and breathing of 2 days, no fever, past medical history, sickle cell disease. Differentials in this patient will be an acute chest syndrome, pulmonary embolism, and pneumonia. So other history I would like to know the nature of the chest pain. Was this sudden in onset? Because other unlikely causes could also come in play here, or aortic dissection, pulmonary embolism. So I want to know if the pain radiates to the back, for cough, for hemoptysis, for wheezing, for easy fatigability, for leg swelling or tenderness, to rule out a DVT, then bone pains. Then past medical history, I would like to know if patient is asthmatic or not. And then I would like to know if the patient smokes cigarettes. Next slide. So the diagnosis here is an acute chest syndrome in a known sickle cell disease patient. So acute chest syndrome is a complication of sickle cell. I won't go into details because of our time. And it is caused by vasocclusion within the pulmonary vasculature. Next slide. It results in sickling of the erythrocytes, which can further cause ischemia, endothelial injury, and it is a common cause of death in sickle cell. So risk factors are listed to us. And then the etiology, I would like to talk about etiology. In children, the infection is commoner, while in adults, it's fat embolism from vaso-occlusive crisis. Because when there is vaso-occlusive crisis, there's release of bone marrow and fat in the venous circulation, which makes the particles go to the lungs, and this can trigger an acute chest syndrome. Next slide. Other etiology are asthma, postoperative complications. When you oversedate the patient following surgery, it can lead to acute chest syndrome. And also when there is excess pain causing hypoventilation. Others include development of in situ thrombi and then rib or sternal infarct causing atelectasis. So the next slide is just a summary of the causes of acute chest syndrome. And then under infection, you can see a list of infection. The commonest causes are chlamydia, mycoplasma, and the respiratory syncytial virus. Others, we mentioned. Next slide. Then this is a short pathophysiology of acute chest syndrome, in which there is increased polymerization and erythrocyte rigidity, which will cause reduced endothelial injury and release of nitrogen oxide, which can lead to lung pulmonary infarction. Other things that can happen is movement of the fat and blood and fat and bone into the lungs, also causing pulmonary infarction. You can also have excessive pain causing hypoventilation and atelectasis, also leading to acute. So it's a multifactorial factor, which as a result of vaso-occlusive crisis or infection can lead to acute chest syndrome. Next slide, please. Then to make diagnosis, there must be a new pulmonary infiltrate, which will show as opacities, which is called density on chest X-ray. And one of the following features, you could have chest pain, you could have temperature. The question is that there was no fever. And studies have shown that in acute chest syndrome in adults, it's not likely that they have fever. Fever is commoner in children. Then other things that will be tachypnea, wheezing, waves, and then there could be hypoxemia. So one of these features with a new finding on chest X-ray will give us a diagnosis of acute chest. Next slide. So what other crises can this patient have? It could have vaso-occlusive crisis, it could have splenic reaction crisis, aplastic crisis, and hemolytic crisis. Next slide. I won't go into details of this. I put this for us to read after the presentation, so you can move on. So just for us to have an idea of what. So next slide. Yeah, so we'll go to the investigations. If you do a chest X-ray, lung ultrasound or chest ultrasound is now the in thing now. Full blood count with regular sound, peripheral blood film, EU and creatinine, because hydroxyurea should not be given to patients who have a low EGF of less than 60 or who are in end-stage renal disease, LFTs, sepsis workup, PTI now, arterial blood gases, and then chest scan can also be done. The next slide. So this is a case scenario of a patient who had acute chest syndrome in sickle cell. In sickle cell patients, bilateral infiltrate can be seen on both sides, patchy opacities on both sides. Next slide. So what chest X-ray shows is usually typically segmental or subsegmental atelectasis with lower lobe dyslection with or without pleural effusion. You can also see other things from complication of sickle cell like rib enlargement, bone infarct, and you can have anemia-induced cardiomegaly. Next slide. So ultrasound, which I said is the in thing now, can show us all these features: consolidation, ear ponchogram, Kelly B lines, and pleural effusion. Next slide, please. There's a classical mosaic perfusion pattern that can be seen on chest CT scan. Next slide. So treatment, yeah, they are the key components of treatment. It is an emergency. So pain control is very important here because pain can actually worsen the acute chest syndrome. Intravenous fluids, antibiotics, supplemental oxygen, blood transfusions. Next slide. So analgesics should be given while we are taking blood samples. At the same time, we are giving analgesics. We can give aspirin, we can give ibuprofen, we can give ketorolac, we can give acetaminophen. And if all those fail, we can step up to opioid. And opioid is preferably given through the patient control analgesia device if it's available in the facility. Next slide. So fluid management, we ID the patient based on the patient's dehydration status. If there's no bland treatment plan for it, but at least maintenance fluid of 3 liters per day is fine. But patient is needed based on their dehydration status. Next slide. So antibiotics, because infection is implicated in almost all acute chest syndrome, antibiotics is very important, and blood pressure antibiotics should be given. Next slide. Third generation cephalosporins are preferred. Ceftriaxone or ceftazidime are preferred, and if we suspect a chest infection pneumonia, we can add erythromycin or erythromycin. If we want to give fluoroquinolone, can also help, can give level or moxie. And if there's a concern for methicillin-resistant Staph aureus, vancomycin can be given. Treatment duration is from 7 to 10 days. Next slide. Intranasal oxygen is important to correct low SpO2, low saturation. And our goal, it has been shown that even giving submetal oxygen to patients without low SpO2 is safe. It's recommended because the normal SpO2 can mask focal areas of hypoxemia in sickle cell patients. So even if the SpO2 is between 90 and 92, we can still give submetal oxygen. Next slide. So the reliable method of measuring oxygen levels in sickle cell patients is to use the core oximeter, which uses spirometry to measure relative blood concentration of oxyhemoglobin, carboxyhemoglobin, methemoglobin, and then reduced hemoglobin. Next slide. So our goal should be 92%, and if the oxygen is insufficient, then we should escalate the treatment. We can give a BPAP, we can send to ICU for intubation, and then we can also do and give an ECMO. Next slide. Blood transfusion is very important in this patient because once the PCV or hemoglobin is less than 10% or 20% of the usual baseline PCV, or the hemoglobin is less than 7 grams per DL, patient might need blood transfusion. Also, if we see a gradual, a sudden drop in PCV from what a daily PCV check and is going down, and then worsening chest findings, patient will require blood transfusion. Next slide. So our goal here should be to increase the PCV to at least 30%, or the hemoglobin to 10 grams per DL. Other things we can do when there is severe chest syndrome. So next slide. Yeah, we can move. So these are other things that can be given. Steroids have been shown not to give, not to help the patient. Then you can also do a bronchoscopy. Next slide. So these are other differentials which I didn't mention earlier: pneumothorax, aortic dilation, empyema, pre-effusion, and ARDS. Next slide. So prognosis is poor. Next slide. And then the question that was asked as other things that can be used, that can be used for. Next slide, please. Okay, so other things that we can use allosuria for is the CML. We can also use to treat carcinoma of the head and neck, psoriasis, though that's off-label, HIV and adjunct treatment, that's off-label, and then for initial thrombocytopenia. So these are the other indications for use of allosuria in this patient. So next slide. And that will be all. These are the complications, usually adverse of use of allosuria: malignancies, immunosuppression, imperfect toxicity, relation recall, and microcytosis. That will be all for today. Thank you for listening.
Well, thank you so much, Dr. Fabemi, for the beautiful presentation and for keeping the time too. Thank you so much. So let's keep the thanks coming on the chat, and then now we'll take comments and questions from the participant first.
Okay, thank you so much for your detailed presentation. Okay, so what I have is an add-on to what you just said. Okay, so for the differentials, these sickle cell disease patients are most times anemic. So it would be good to add or to also have at the back of your mind that this patient could actually be in an anemic heart failure secondary to maybe anemia. And then secondly, in the investigations, I was thinking that you can also add electrocardiography, cardiac enzymes, as well as D-dimer. You know, in one of your differentials, you actually talked about pulmonary embolism. So a D-dimer is not out of place in the aspect of investigating this patient as well as an echocardiography. So, you know, in one of your differentials, you mentioned acute coronary syndrome, which can actually occur. You know, basically what this patient had was a vaso-occlusive crisis complicated with an acute chest syndrome. You know that in the acute chest syndrome, what basically happens is that there's an atherosclerotic plaque or thrombus that is actually formed in the pulmonary vasculature that actually led to the acute chest syndrome in this patient. Then I also want to find out something from you. In this patient, did you add hydroxyurea as part of the medication, or you just mentioned it as it can be given in other conditions? I just need to know, because I know one of the indications for use of hydroxyurea is when the patient has a severe vaso-occlusive crisis with complications, of which this patient has a vaso-occlusive crisis with acute chest syndrome. So I think this patient would benefit from hydroxyurea as part of the medications he or she should get. Thank you so much.
Thank you, ma. It's part of the treatment on slide 39. I didn't go through it again. I put out the making of action and other things that will give as a long-term management strategy for the patient. Slide 39.
Okay, so can you just tell us how, because the person, even if it comes in this way, may be asked in a separate way, how hydroxyurea can be helpful for a sickle cell disease patient? Why is it used? Like the mechanism behind use of hydroxyurea?
Yeah, it's useful. It helps to increase the beta hemoglobin in red blood cells, which is one of the ways by which the risk of acute chest syndrome can be reduced. It's the only medication who have been shown to decrease the increase of the incidence of acute chest syndrome. It reduces the frequency by 50% in adults and 30% in children. The mechanism is by increasing the concentration of fetal hemoglobin in red blood cells.
Okay, good. And again, to the fetal hemoglobin actually helps to make the red blood cells bigger, rounder, and more flexible. You know, these the sickle cells, they are usually sickled and they are very sticky. So that's why most times they are at risk of atherosclerotic plaque, because they stick to the walls of the vessels. And then over time, they become thicker and thicker, and then they occlude. And then what happens is there's poor perfusion to the organs, to maybe the heart muscles or to the lungs, and then they present with that. So basically what it does is that it modifies the shape of, like for the sickle cells, it actually helps to modify it. It makes it look rounder, more flexible, and then also make it bigger. And you know, the fetal hemoglobin is somehow close to the adult hemoglobin, although it's a fetal hemoglobin. So they are less likely to be at risk of crisis, because the fetal hemoglobin, the shape of the fetal hemoglobin is similar to that of the adult hemoglobin. So what it basically does, as you said, is that it induces the formation of fetal hemoglobin, which will prevent further crisis in this patient. Then there are other conditions too, aside sickle cell disease, where hydroxyurea can also be used, like in cancer patients. So basically what that does is that it inhibits the RNA nucleotide synthase. So it prevents further production of DNA, which will lead to cancerous cells or mutation of cancerous cells. So aside sickle cell disease, it can also be used for malignancies as well. So that's what I have to say. Then in addition to, for severe anemia, you can use it in sickle cell disease, and also in a patient who has recurrent severe painful crisis. That's in the sickle cell crisis, you can actually use it. Thank you so much. Then again, so I don't know if there's a role for VTE for this patient, for venous thromboembolism prophylaxis for this patient, or is there also a role for glucocorticoids in this patient, or an inhalational nitric acid oxide for this patient? So I just need to know. Then again, so yeah, okay, that's what I have to say. Thank you.
So thank you, Ma. So I put it there too, but I didn't have time to talk to go through it. What steroids have been shown to do is to reduce the length of hospital stay. But however, the use of steroids has given a higher rate of rebound vasocolonic crisis. It will reduce hospital stay, but there's tends to have a rebound vasocolonic crisis. There is also an increase of readmission and increased risk of fat emboli. So generally speaking, steroids are not advisable for these patients. And I'm not sure I go to that question, but
the VTE prophylaxis. The VTE prophylaxis.
Yes, it can be given. That I missed that. I missed that in the in the treatment. It was very important because DVT, there are complications they can easily have.
Yeah, thank you.
What about nitric oxide? Should I ask about nitric oxide, sir?
I'm not sure about nitric oxide. I'm not sure.
It's neither here nor there. It's when the patient is having an acute coronary syndrome, because there are also attributes of acute coronary syndrome. So basically, what differentiates it is the enzymes, the cardiac enzymes, and also ECG. That's what differentiates it. So that was why I had to tell him that it should be one of the investigations this patient should do to differentiate the acute chest syndrome from an acute coronary syndrome, which can actually occur in this cell disease patients. Thank you. And they have the same presentation.
Okay, thank you so much, Dr. Florence, for that beautiful contribution. Thank you so much. A lot of thanks on the chat. Dr. Schreiber is saying thanks. Dr. Ibinabo Amakri, Dr. Telma is saying thanks. Dr. Araga, and then Dr. Ibinabo Amakri is saying acute chest syndrome is an indication for exchange blood transfusion. That should be in the patients, in the management of the patients. All right, thank you so much, Dr.
Yeah, I mentioned that it's part of the treatment.
All right, okay, thank you so much. So now I'll hand over to our teachers. Dr. Christopher Ma.
Okay, thank you so much. Thank you. We really appreciate all the comments. Thank you so much, the presenter. Thank you. Thank you, Dr. Kalamama and Dr. Kele. Thank you.